Yeah. Should I stop sharing my screen, Dr. Manas? You will do some introduction.
Yes. Suchanda, you can start. No, you can start introduce both Dr. Ali and Dr. Venkatesh, and then start off the program. We cannot hear you. You have to unmute yourself.
Sorry. Good evening, everyone. Today we are having the 22nd session of exam online, and this was started just as a preparatory for exam, and now it has become a regular feature. And the process is one in which both we learn as an examiners and the students, of course, have their exercise and their mock testing before the exams. So this 22nd session, we have two great professors with us who will conduct the exam. We have Professor Aliasgar, who is from Tata Memorial Hospital, Mumbai, and he is a what I should say, he's a scholar on neuro-oncology in India, I should say right now. And he will be taking sessions on pathological slides. And we have Professor Venkatesh, who is from NIMHANS, Bangalore. And he will be dealing with the research methodology, which is gaining more and more importance these days in the exams actually scenarios. And we all need to know about a little bit about how we do research and what statistics methodology we use and all those stuff. And we have three brilliant students with us, Dipesh, Ankit, and the third person is yet to join. His name is Chirag. The third person?
Vivek, Dr. Vivek.
Yeah, Dr. Vivek, sorry, I was just not recollecting the name. So we have Dipesh, Ankit, and Vivek who will be joining us as students, and they're just going to give their exams very soon. Then the first, I think, will be Dr. Ali, who will be taking the exams. Over to you, Dr. Ali, and all the best to the students.
Yeah, thank you. Thank you, Dr. Suchanda. Thank you, Dr. Manas, and for what is, I believe, developing into a very fantastic online exam forum for students. I'm going to be discussing and asking questions related to neuropath. That's what Dr. Manas had asked for. So what I will do, I'll just share my screen. Can I share my screen, please? Okay.
Yeah, and I'll be keeping the time, Dr. Ali. So it will be around 45 minutes for you today. And we have a little bit more because we have two speakers and 45 minutes for Dr. Venkatesh. Right.
Sure. Hopefully we should finish in that time. Can you all see my slides? Ankit, Chirag, all of you all, can you see the slides? Yeah.
We can see.
Yes, sir.
All right. So Ankit, Chirag, and Vivek. Vivek has still not joined. So the format for this session will be that I will show you all cases in the form of specimens or slides, pathology, and you all will need to describe as directed. There will be questions and answer those specific questions. We will also review those answers after a couple of questions, and we can have discussions at that point of time. And at the end of each case, there can be a discussion and clarifications if you all have any. Right? So,
sorry. I am here, Dr. Ankit and Dr. Dipesh is a student. I am here to just to coordinate. I am not a student.
Okay. Ankit, Dipesh, sorry.
Dr. Vivek is joining. Yes, sir.
Yeah. So Ankit and who's the second student?
Dr. Dipesh.
Dipesh. Right. Okay. So what we'll do is Ankit and Dipesh, we'll start with you one by one. And if Vivek has joined, then he will come in at that point of time, or we'll carry on with you all till then. All right? Yeah?
Yes.
Okay. So all the best. So Ankit, maybe you will start with this case. Yeah, okay. So, Ankit, this is a specimen. I need you to take 30 seconds and describe the specimen, and also then go ahead and give your diagnosis based on that. Yeah, Ankit.
Dr. Ankit, you are muted.
You can unmute. Dipesh, Ankit, both of you keep unmuted.
Yes, sir. Sir, this is a coronal section of brain, suggestive brain specimen, suggestive of a right-sided temporal mass lesion, which is extending into the capsuloganglionic region, and there is also a midline shift towards the left. This lesion is probably glioblastoma multiforme because it is showing cystic, it is showing degenerative necrotic component and cystic degeneration.
Right.
And some hemorrhagic.
Can you be a little loud? Ankit, can you be slightly louder?
Yes. 1 second.
Yeah.
This is also showing some necrotic component and intralesional, intratumoral bleed as well, sir.
Right. So I think you were spot on in the diagnosis. So it is, as you rightly mentioned, the coronal section showing a heterogeneous, ill-defined infiltrative lesion occupying the temporal lobe and extending into the insula with necrosis, hemorrhage, as you said, and mass effect, and probably uncal herniation. I would not commit right or left because you don't know the anterior posterior in this coronal section right now, but that's fine. And your diagnosis was a glioblastoma. But again, you were right. Now, what do you think would have been the presumptive clinical presentation of this patient?
Sir, patient might have presented with symptoms of sudden deterioration in the form of depression, in the form of depression in the consciousness, and there may be pupillary dilatation at the time of presentation as the patient has midline shift and uncal herniation as well. All the features of the mass lesion which can cause raised intracranial pressure will be there in this patient. Headache, patient may have seizure also, and vomiting, and a significant neurological deficit in the form of contralateral side hemiplegia, plegia or paresis.
Correct. Again, so this would have been a combination of raised intracranial pressure and focal symptoms, including seizures and neurological deficits, depending on the lateralization, and also cognitive dysfunction, which may have preceded these symptoms before the acute decompensation. Do you think this specimen is antemortem or postmortem?
Sir, this will be postmortem specimen.
That's a trick question. Obviously, it is postmortem. You won't have the coronal section of the brain. But do you think this was the cause of death in this patient?
Sir, maybe, sir, but I'm not sure. Because
again, most probably it may have been the cause of death in this patient. Good. Okay, so what are the pathological features of glioblastoma, the classical pathological features of glioblastoma? Can you enumerate on pathology, on microscopic slide examination? What would be the features of a glioblastoma?
Sir, there will be lesion which is well circumscribed with irregular margins, and the lesion will be having intralesional
microscopic. Ankit, on the slide, histology slide, what would you see in a glioblastoma?
There will be necrotic component with necrotic cells with increased blood supply, increased capillary in the rim of the lesion, and maybe.
So what are the hallmarks of glioblastoma on pathology which can make the diagnosis of a glioblastoma as compared to the other gliomas or astrocytomas?
Sir, necrotic tissue with peripheral rim of the tissue rim of the tumor will be having increased blood supply. So there will be capillary formation, neoangiogenesis will be seen. And
so the classical findings on pathology will be, of course, so this is a glial tumor from astrocytic lineage. There will be anaplasia in the cells with mitosis indicating high proliferative potential. And there will be microvascular proliferation, MVP. Yeah, that is what you mean by vascularization. This is a pathognomic finding in glioblastomas, along with necrosis, different types of necrosis, but geographic necrosis is usually the type. Palisading geographic necrosis is what is described in glioblastoma. So these are the characteristic findings which will clinch the diagnosis for the pathologist. So in a glioblastoma, this patient, what would be your principles of management for a glioblastoma? And what are the prognostic factors in glioblastomas?
Sir, principle of management plan will be surgical first, and to review the complete or gross total excision of the mass lesion, along with after that, we'll review the histopathological diagnosis and look for the different markers, which like MGMT, P53, IDH mutation, and this can be diagnosed, and this can direct us for the this can be diagnosed for important for the planning of the further chemotherapy and radiotherapy management.
You know what that further management is?
Sir, the further management will be chemotherapy. Temozolomide is the mainstay of treatment, which can be given, and whole brain radiotherapy can be given post-operatively. At the tumor, whole brain radiotherapy plus tumor bed radiation.
Okay, so I think you answered most of it correctly. Surgery, of course, and that is safe maximal debulking. And the adjuvant therapy is what is described as the Stoop protocol, which is concurrent radiotherapy. It is not whole brain radiotherapy. It is external beam radiotherapy to the tumor and the margin around it. Whole brain radiotherapy used to be given early. It is no longer given unless it's a diffuse gliomatosis. And this concurrent phase in which temozolomide is given with the radiotherapy for those 5 to 6 weeks is followed by adjuvant temozolomide for 6 to 12 cycles, right? And prognostic factors, you did mention molecular IDH and MGMT, you are correct. They do not determine the type of treatment of glioblastomas, but they are prognostic, right? So that means you will be able to understand how the patient will do, but the treatment usually does not change based on that. If the diagnosis is glioblastoma, there are some changes in the recent 2021 classification, and we'll discuss it a little bit. Besides that, age and extent of resection are also important prognostic factors in glioblastomas. Good. And finally, as I was saying, do you have any idea about the WHO classification of gliomas, the new WHO classification of gliomas, and what is new in the WHO classification of gliomas? You did mention something about molecular in your previous answer, right? IDH.
Yes, sir. Yes.
So does that have some relevance and bearing in the new classification? Which is the current WHO classification in neuropath that we follow?
Sir, 2016 classification.
Right. And what does that say? So 2016 is not an independent classification. It is a update on the 2007.
Okay.
And there is a 2021, which is likely to come any day soon now. And what are the features or gliomas in 2016? How are gliomas classified in that? So it is heavily based on molecular now. 2016 already had IDH mutation as a very important component of classification of diffuse astrocytic and oligodendroglial tumors. And in 2021 to WHO, which is going to come out soon, it is further reinforced the importance of IDH mutation and classified diffuse gliomas into astrocytoma IDH mutant, oligodendroglioma IDH mutant, and 1p19q deleted. And this is irrespective of the grade 2 or 3, or even in astrocytoma grade 4 tumors are IDH mutant are categorized into this rather than glioblastoma, which is defined by the absence of IDH, wild type IDH. Okay, this is what is important to understand, that molecular classification has significantly made inroads into the new classification WHO. All right, good. So I think you did well, Ankit. Is there any questions before we move on to the next case with Dipesh? Dipesh, right?
Yes.
Yeah.
Sir, good evening. Sorry to interrupt. Dr. Vivek has not able to join because of he is stuck somewhere, and Dr. Bharat is now as a third student. We have make him panelist, so he's there in the panelist. Yes,
okay.
Thank you.
Dipesh, Bharat, welcome, and Bharat, Dipesh, Ankit. We'll move on to the next case then.
Ali, can I chip in with one comment?
Yeah, sure.
I'm Dr. Suresh Nair.
Yes, sir. Yes, sir.
Yeah.
Very much.
Say you have discussed it very well. But just to tell, say something more, which I don't know, people may ask. One is, the orals, it is more of radiology. Okay, I will discuss it next week. Okay. But what I wanted is that student was telling.
Your sound.
Say glioblastoma, the astrocytomas are not good. My sound is not good.
Yeah, it was breaking in between.
So
now it's okay. Now it's fine.
Yeah, say high-grade gliomas are well marginated. Astrocytomas are not that well marginated. And other thing is, you told about probable cause of deterioration, and correctly that candidate told it could have been angle herniation. But the next step is
again, I think I lost the sound. Can anybody hear Dr. Nair?
what is how it progresses? Angle herniation, how it progresses. They will decorticate. So they are going for decerebration because the herniation is occurring below diencephalon. But books may tell even decortication, but that is not correct. So otherwise, central herniation, decortication, decerebration, like that they go, medullary failure. So here the decortication, this angle herniation, it goes below diencephalic level. So there won't be decortication. Okay, fine. Proceed. Right. Okay.
Yeah. Thank you, sir. And I think valid points. So I think we'll move on to the next case, and Dipesh, Dipesh will answer these questions. So Dipesh, a relatively easy question. Can you describe the specimen and give your diagnosis?
Right.
Yes, Dipesh. I don't think this is very complicated.
Yes, sir. Looks like a fourth ventricular tumor.
Fourth ventricular. Can you describe it What is this? You can see my cursor moving around.
Sorry, sir. I think it is arising from the leptomeninges, possibly meningioma.
Yeah. You want to describe it a little bit, or you are
It is a
certain of your diagnosis?
solid tumor arising from the dura with wide dural base and extra-axial tumor not infiltrating the brain surface, cortical surface.
Okay. Right. So it is a well circumscribed dural base mass, brownish tan pink. Okay, granular appearance in cut section with a surrounding dural margin seen. And you're right, extra-axial. So you think it's a meningioma? Yeah.
Yes, sir.
Where do you think this meningioma was located?
Convexity meningioma.
Right, most probably convexity.
Yes,
And
sir.
you think this is an antemortem, post-mortem specimen?
Antemortem.
Can be antemortem, right?
Can be. Yes, yes, sir.
Yeah? Okay. So briefly, can you tell us about epidemiology and clinical presentation and risk factors for meningiomas? Briefly. When do they occur and when do they occur? Clinical symptomatology and predisposing factors.
Regarding the epidemiology, meningioma are most commonly seen in the female patient during the fourth decade. After the 40 years of age, presentation depend upon the location. Mainly they present with the headache and neurological deficit. Depending upon the location, if they present in the convexity, they will present the opposite contralateral site weakness or seizure if they are infiltrating the cortex. And
Okay. The risk factors, predisposing conditions, do you know?
the risk factor depends exposure to the radiations, previous history of any radiation.
Okay. All right. So, yeah, I think it is the commonest benign brain tumor. Quite often it can be incidental also, but many will be symptomatic. And you're right. They're more common in females in their 50s, 6th and 7th decades. Risk factors, you mentioned radiation. Neurofibromatosis 2 is also an important risk factor. In fact,
Yes.
neurofibromatosis, neurofibromin gene mutations are even seen in the sporadic non-NF2 associated meningiomas and important in the pathogenesis pathophysiology. Yeah, okay. So, how do you classify or grade meningiomas pathologically?
Warning in progress. Warning in progress.
Dipesh, you are with us?
Yes, sir.
Yeah.
Yes, sir. Yes, sir.
Yes, yes.
There are different described types of the meningioma. Most common meningothelial, meningioma, anaplastic meningioma, atypical meningioma, transitional meningioma.
Is there some grade to these meningiomas, or all of them are same?
Grade 1, 2, and 3 are there.
Okay, fine. Grade 1, 2, and 3. And do you know?
Grade 1, yes, sir. Grade 1 include transitional meningothelial meningioma. Grade 2 include atypical meningioma, and grade 3 is anaplastic meningioma.
Right. In grade 2, are there any other hallmarks which can diagnose a meningioma to be grade 2?
Actually, we have to look for the MIB index and also the number of mitosis per high power field.
Good. How much is it, you know? Do you know the cutoff?
Yes, sir. If it is less than 4, then it is grade 1. 4 to 20 mitosis per high field fever is grade 2, and grade 3 is more than 20 mitosis per high power field.
And do you know whether any of the different histotypes themselves, by virtue of their type itself, become grade 2 or grade 3?
Sorry, sir.
Okay, fine. All right, so good. So I think you answered it correctly. So there are many histotypes in meningiomas. We need to understand that, and they have certain pathognomic features. A large number of them fall into grade 1 category. Grade 2, as you rightly said, is atypical. So any of the histotypes showing any of these features, either showing less than 20 or more than 4 mitosis per high 10 high power fields, or at least 3 of these other features, will categorize as atypical. In addition, brain invasion is upgrades the tumor to atypical. Pathological brain invasion, not at surgery what you see, but pathological brain invasion, islands of meningioma within brain parenchyma seen by the pathologist. And chordoid and clear cell types themselves are grade 2. Similarly, papillary and rhabdoid types become grade 3. And if any of the other types show more than 20 mitosis, or they have obvious carcinoma, sarcoma-like appearance, they become grade 3. And this is important because it determines what would be your prognosis and your follow-up treatment, including adjuvant therapy, right?
Yes, sir.
So the commonest varieties are meningothelial, fibrous, transitional. Do you know some pathological features of these? Can you describe? Microscopic features of meningothelial or fibrous or transitional meningiomas. What are they characteristically described as? Okay.
No, sir.
So these are the commonest meningiomas. Grade 1s are themselves the commonest. Almost 90% of all meningiomas will be grade 1. Very few would be atypical and grade 2, though that is changing with, again, the new WHO 21 classification. Meningothelial meningiomas are characterized by lobular syncytial pattern. Fibrous meningiomas are spindly cells, elongated spindly cells with a lot of collagen and reticulin, and transitional, as the name suggests, has a mixture of both these with a lot of whorls and psammoma bodies, which are quite classical for transitional meningioma. Yeah, these are important pathological features. Of course, the other types have their own pathognomic features, but these are the commonest which you should be aware of. So how would you manage, and what are the prognostic factors in meningiomas? For some reason, that answer displayed itself. So extent of resection is an important prognostic factor. Do you know how to grade the extent of resection?
Yes, according to Simpson grading, the grade 1 is equal to excision of tumor plus involved bone and excision of dura. Grade 2 include total excision of the tumor plus coagulation of the dura. Grade 3 include the total excision of tumor only without removal of the dura. Grade 4 include the partial excision of the tumor. And grade 5 is equal to biopsy, partial excision of the tumor.
And why is this important? What is the prognostic importance?
It is a prognostic value.
What is the prognostic value?
To determine the recurrence.
Right, recurrence rates increase as the Simpson grade increases.
Grade increases,
right?
yes.
I think between 2 and 3, you were slightly, I think you were almost correct. So 2 is complete tumor excision with coagulation of affected dura, right? I think you mentioned that. Good. Any other prognostic factors besides the extent of resection? Again, my computer is jumping the gun. So bone invasion is presumed to be an aggressive feature of melangiomas, not hyperostosis, bone invasion. And there is I would say a debate between the prognostic importance of convexity versus skull-based melangiomas. And more importantly, pathologically, is markers which have now found their way into the latest WHO classification, which indicate anaplastic potential, which includes TERT and CDNK2A deletions. All right? Okay.
Yes. Yes, sir.
Fine. Okay, good. Well done, Dipesh. Is there any further questions, or we can then move on to case 3 and Bharat can come on? Dr. Suchanda, you can tell me if I'm going to exceed my time limit.
No. You have 15 minutes more.
Okay.
Very nice. Actually, one thing is, you told that the bone involvement is not, hyperostosis is not the thing, but bone is spicules and lytic area. Very nice. Okay. Very nice. You told bone involvement.
Right.
Okay.
Okay. All right. Fine. Okay. So, Bharat, you are up next. Describe this specimen and give your diagnosis.
So it's an interaxial space occupying lesion, which is present in the temporoparietal region with compression of the ipsilateral ventricle and dilation of the contralateral ventricle, causing
Okay. So this is a coronal section of the brain again, first.
Yes,
to start with. Intraaxial lesion on this side. Yeah, we are not sure left or right. But what is the location? Can you make out? What is this? What is this? And what is this? You can see my cursor.
Cilian feature, sir. It's
so what is this region?
Insular area, sir.
Yeah, so it is a
insular glioma.
Prehensile infiltrating lesion in the insula and the deep basal ganglia, right?
Yes,
there is no necrosis or hemorrhage like we saw in one of the earlier specimens.
Yes, sir.
So what is the diagnosis?
Most probably it's low-grade glioma.
Yeah, so you would say it is a diffuse astrocytoma. Yeah, it may not be low grade. Looking at its mass effect, it may probably even be grade 3. But you're right, it's an infiltrating astrocytoma. Okay, Bharat. Now I want you to look at the opposite side, okay, where you can see the insula. And can you, starting from lateral to medial, identify the different layers over there, the neural substrates? They're very well seen on this specimen. And you can start 1, 2, 3, 4, 5, 6, 7, like I have mentioned. You got the question, Bharat?
Yes, sir. I got it, sir.
So what is 1? The normal anatomy is seen on this side, yeah? I have marked it with a black circle. 1 indicates, okay, I'll start that for you. That is the insular cortex. Yeah? What is 2?
2 is external capsule, sir.
External? Okay, what is 3?
3 is claustrum, sir.
Okay, what is 4? Very good. 4 is this thin white matter, again below the claustrum. So you want to change your answer for 2?
So 4 is external capsule, I think, sir.
So what is 2? Okay.
Extreme.
Extreme capsule. Yeah, 2 is extreme capsule. Okay, what is 5, 6, and 7 then?
6 is internal capsule. 7 is caudate nucleus. 5 is
putamen.
Yes, sir.
Right, I think you're right. Very good. Well done. So this is the classical anatomy in coronal section of the insula. Right, insular cortex, extreme capsule, claustrum. External capsule is the place where all the associative fibers cross over, including the inferior front occipital fasciculus. And then you have the putamen, internal capsule, and head of caudate. Very good. This is important surgical anatomy because of surgical implications. Okay. Do you know of any anatomical surgical classification of insular tumors based on the extent of involvement of anatomical regions?
Sir, it's divided into four types, sir. One line will be passing through the ciliary fissure.
Right.
One more line will be passing.
The vertical line passing through foramen Monroe.
Okay, sir. Yes, sir. Foramen Monroe.
Okay. What is that classification?
It's a Yasaki classification, sir.
Is that the Yasaki classification or it is some other classification? So the original Yasaki classification is a more broad classification of limbic paralimbic tumors, of which these types 3A, 3B, 5A, 5B are the insular ones. 3A only purely insular, 3B is opercular insula frontal. 5A and B are both temporoinsular, involving one of them involving the mesial temporal lobe. Right? Okay. And what you said is the Berger-Sinai zones classification. Sylvian Fisher, foramen Monroe, zone 1, 2, 3, 4. And this is more of a practical surgical strategy oriented, where zone 1 and 4 are easier to access compared to zone 2 and 3. Good. So what are the approaches to the insula?
Sir, one is trans-Sylvian, trans-cortical.
What are their pros and cons?
So trans-Sylvian, we can see the see the MC and we can save the MCH. If we go through trans-cortical, the chance of speech disturbance are more in trans-cortical.
Okay, so trans-Sylvian, you split the fissure, which may have its own set of difficulties, and you encounter the vessels, which you will have to work between, risking injury to them. Transcortical avoids that, but you have to go through opercular regions, which may be eloquent, especially on the dominant side where you may have speech deficits, right? Okay. So what is the relevant vascular anatomy, which is important here? Which blood vessel, which vessels, and specific segments, if you can name.
M2, M3 we need to see, sir.
Sorry, M2, M3?
M2, M3 lenticular striate vessels we need to see, sir.
Correct. I think you're right. So M2, M3 and M4, if you're in the opercular, you're going transcortical, even the M4s will come there. And the lenticular striates, which are very, very important to preserve. And actually, while planning surgery, these have to be kept in mind. Okay, good. I think good, Bharat. Well done. Yeah. So is there any discussion case, any questions? Dr. Nair, you have, Dr. Manas, any comments or any additions to make? We move on to case 4 then.
No.
Yeah. Okay, fine. All right. Then in that case, we will go on to the next case, and I will ask who wants to come. Ankit again, starting with Ankit. Yeah?
Yes, sir.
Okay, Ankit. Okay, now Ankit, now this is pathology slides, so any microscopic slides. Slightly more difficult, but I can, can you make out anything on this? Okay, I'll give you a clue. That the slides are microscopic slides showing some tumor which is having a biphasic pattern. It is showing Rosenthal fibers here. These eosinophilic linear spindly structures showing EGBs, eosinophilic granular bodies, and hyalinized vessels. Does that ring a bell? These pathological microscopic features fit into what
astrocytoma. Astrocytoma, sir. Pilocytic astrocytoma.
Good, good, very good, Ankit. Yeah. So these are the classical features of pilocytic astrocytoma, and it is a WHO grade 1 tumor, typically described to have biphasic pattern, elongated pyloid cells, and pyloid is why the name comes from. And EGBs and Rosenthal fibers are quite diagnostic. You should remember that it can show atypia and sometimes aggressive looking areas even with microvascular proliferation, and we saw that in glioblastomas, and therefore sometimes can mimic glioblastomas. Okay, are you aware of any molecular markers? I'm sorry. You're aware of some molecular markers with, which are very, very important in pilocytic astrocytomas?
Sir, BRAF and BRAF one thing, and the other one is.
Yeah, you're right. So the BRAF pathway is very, very important. It's actually a nitrogen activated pathway, which is a pathway seen in a lot of cancers, but the unique thing in pilocytic astrocytomas is predominant and is almost the only single pathway which is abnormal, and therefore makes it very, very amenable to being targeted, right? And there are two kinds of BRAF markers here. One is the mutation in V600 and one is the fusion. It's a fusion product. Coming to pilocytic astrocytomas, Ankit, where are they normally located in the CNS?
Normally located at the.
Where would you find pilocytic astrocytomas? You know, my previous slide had one.
Yes, sir. In the posterior fossa.
Can you be more specific in the posterior fossa?
In fourth ventricular ependymal roof of the fourth ventricle, sir.
What is the roof of the fourth ventricle?
The ependymal lining, which is there over the.
Okay, besides posterior fossa, where else can they be found?
They can be found in whole the craniospinal axis, sir. In the.
What are the preferred locations? What are the preferred locations? Most common locations. Posterior fossa, you said one.
Yes, sir.
Then where else? Spine is another one. One very other important location, very common and very important.
Sir, in temporal lobe. No, sir, I'm not sure.
Okay, is there any kind of syndrome in which you get pilocytic astrocytomas? Are you aware?
Sir, in neurofibromatosis, it can be present, sir.
Neurofibromatosis, which type?
Sir, in type 2, sir.
Type 2?
Neurofibromatosis.
Type 2 or type 1?
Type. Sir.
Okay, and where is it in
type.
that? Where is it located in that? Okay, so yeah, so cerebellar astrocytomas, pilocytics, Permian is the commonest. That's the roof.
Yes, sir.
And that's more common than hemispheric. Optochiasmatic hypothalamic gliomas are pilocytic astrocytomas seen in NF, yeah, and NF1. And besides that, brainstem and spinal cord can also have. These are the two commonest ones, cerebellar and optochiasmatic, and they can be differentiated, though they both are pilocytics. More often, the cerebellar ones are BRAF fusion positive, whereas the optochiasmatic ones, especially those associated with NF1, are BRAF V600E mutation positive, right?
Yes.
Okay. Common in children, and in fact, commonest primary brain tumor in children actually, with optochiasmatic being associated with NF1. All right, yeah, it is optochiasmatic glioma, optic nerve gliomas are one of the diagnostic features of NF1. Yeah, you should know the criteria for NF1 and NF2. What is NF2, since you mentioned it?
Sir, the other variety of neurofibromatosis, which
is the commonest tumor in NF2?
Sir, vestibular schwannomas.
Correct. Yeah. So don't confuse the two, right? Okay.
Yes, sir. Yes, sir.
And what is the typical radiology of pilocytic astrocytomas? Just briefly tell me.
Sir, there will be the solid, the cystic component along with the mural nodule in the lesion.
Good. Correct. So cystic with mural nodule is the majority, but it can also be completely solid ones, especially optochiasmatic and mixed varieties. And usually the solid component intensely enhances.
Yes.
All right.
Yes,
okay.
Sir.
And what is the treatment and prognosis of these tumors? Tell me for the cerebellar ones and for the optochiasmatic ones, just briefly.
Sir, treatment will be complete excision of the tumor, cervical excision.
For all of them?
No, sir. For posterior fossa, cerebellar.
All right. And for optochiasmatic?
For optochiasmatic, expectant observation with adjuvant with chemoradiotherapy. Sir, optochiasmatic, I am not so sure.
Right. So surgery is the mainstay for posterior fossa and for spinal tumors. For optochiasmatic, you need to evaluate for NF1, right? Because a lot of the optochiasmatic pilocytics in NF1 can be very indolent and they can be observed. However, in some cases, especially sporadic, surgery may be required for a biopsy or debulking in rare cases. And you're right, chemo and RT are the mainstay of treatment, especially since this occurs in children. Chemo is often preferred over radiation. All right, good. I think you did well. Again, Ankit. Anybody else has any questions? Or if we have time and I can go on to the fifth case, or if it's over, then
I think we'll switch over now because we have just finished 45 minutes.
Okay. All right. Fine.
Yeah.
All right. Well done. Well done. Okay. So over to Venkatesh then.
Yeah. Over to Venkatesh.
Thanks, Chief. Brilliant as usual. Okay. So let me just set up my video, although I'll turn it off later. Yeah. So I think we'll switch tracks completely now. And this is something which is not directly neurosurgical, but still very relevant to neurosurgery. So let me start sharing my screen and we'll just jump right in. Yeah. Okay. My screen is seen to everyone?
Yes,
Yes, sir.
Yes.
Okay. Okay. Okay, so let me start. So we're going to talk now briefly about research methodology and statistics. So that was the topic that was given to me. So the format will be the same, pretty much as what Dr. Ali did. I'll be describing a scenario, and then I'll be asking certain very specific questions. So please provide a very specific answer. Okay. And I'm not maintaining time, although we are supposed to maintain time for asking. I'm not maintaining time, but please answer as soon as possible. Okay. And if you don't know, just say pass, and then we can ask the other participants to answer. And I will give explanations following each question. So very simple. So whom shall we begin with? Shall we start in alphabetical order, which means Dr. Ankit will get it again. Are you ready, or do you want me to start with Bharat, or is that okay?
Yes, sir, I'm ready.
Okay, so let's start with Ankit. So this is the first scenario. So a neurosurgery resident in casualty notes that quite a few of the patients who are brought to the emergency department with traumatic brain injury have a history of alcohol intake. Okay, so she wants to study how many patients who sustain traumatic brain injury in road traffic accidents have consumed alcohol prior to the accident. So she just wants to know. So she now gathers the relevant data and she wants to present it. Okay, so what kind of a study design would answer this question? That is the first question. And the second question is, this kind of study design that we are talking about, what statistic is it going to present? Okay, so
yes,
Ankit,
sir,
what is the appropriate study design and what is the statistic that it will present?
Yes, sir. What study will be the appropriate study design, which is a type of observational study design.
Okay.
And
what is the statistic, or what kind of data would such a, so when you gather the data, you have to present the results. So
yes,
what
sir.
statistic will you be generating from this kind of a study design?
The study design will be giving the statistic of incidence.
Okay, so incidence.
Yes, sir.
Okay, so let me jump to the, tell me, please go ahead. Please go ahead. Anything more you want to add?
Two more things, but I am not able to recollect the part, sir.
Fine, okay, so let me give you the answer. Okay, so so this actually will not be a cohort study. This is going to be something called a cross-sectional study, and I will explain why. Okay, and always remember that a cross-sectional study will generate a very specific piece of data, and that's called the prevalence. It's not the incidence. Okay,
yes.
So the incidence is the occurrence of a disease over a particular period of time. The time is important. Okay, whereas a cross-sectional study will generate the prevalence, and let me explain why. Okay, so in a cross-sectional study, what happens is you select the subjects because they're part of a very specific group. So my advice to all of y'all is try and take screenshots if you want to, because these are very basic but very standard things that I'm telling you. Okay, so the subjects are selected based on being part of a specific group based on some criterion. So here, what is the group? Those that are presenting to the casualty with traumatic brain injury due to an RTA. Okay, what you're identifying is the frequency of a specific disease or a risk factor. So here, what is the risk factor? The risk factor is alcohol intake. Okay, so this is specifically what you identify from a cross-sectional study. So this is, remember, it's a snapshot in time. Okay, so the resident is looking at a specific period of time, let's say 1 week or 1 month, and you're not following up any of these patients over, say, 1 month or 2 months. You're not doing any follow-up. You're picking a period of time, 1 week or 1 month, and you're looking at that specific period in time. So it's a snapshot in time. So there is no longitudinal or follow-up component, which is why it's called cross-sectional. You're taking a cross-section in time. Okay, so what can you identify here? What, as I said, it's the prevalence. So, or the risk factor. Okay, so what is the prevalence here? You're studying the prevalence of alcohol intake in patients who present with traumatic brain injury after a road traffic accident. Okay, so very specifically, cross-sectional studies generate prevalence data. So when you look at something once at one point in time, that's called a cross-sectional study, and it generates prevalence. So it cannot determine how much the studied factor, for example, alcohol intake, how much does it increase the risk of traumatic brain injury? That you cannot generate that data here. That's called relative risk. You cannot also generate an odds ratio. That is, what is the odds of having a traumatic brain injury after alcohol versus the odds of having it without alcohol intake. That's the odds ratio. You can't determine either of those from this study design. You can just get a prevalence. Okay, so this is one of the simplest study designs. As you said, that's correct. It is indeed observational. It's an observational study design. Okay, and the results, when you write up a paper, how will you present it? You will say something like 60% of the patients who presented to casualty with traumatic brain injury after an RTA had consumed alcohol prior to the RTA. Or you can say the prevalence of alcohol intake in patients presenting to emergency services with TBI after an RTA was 60%. You can put it in either of the ways, but this is how you'll present your results. Okay. And when you read this kind of result in a paper or an abstract, you know that it's a cross-sectional study. They've just looked at a cross-section. Okay. Now, I think Dr. Bharat, let me ask Dr. Bharat, because I'll just go in alphabetical order. So this is the second scenario that I'm giving you. So a neurosurgeon has operated on 15 patients with medial sphenoid wing meningiomas, okay, all of which have complete ICA encasement. I've shown an example in the picture here. So he wants to analyze the outcomes. And what are the outcomes he's interested in? What are the rates of vascular injury? What is the rate of visual improvement? What is the clinical outcome? So he wants to analyze all this and he wants to publish his results. So same questions again. What kind of study would it be if he performed this analysis? And what metrics can be determined from this kind of a study? Same questions as last time. What kind of analysis would this be? And what kind of metrics would this particular study generate?
So it's a analytical study. It's a case control study because we want to test a hypothesis.
Okay. Anything further? The second part of the question or the second question? If you don't know, you can say pass, and then we'll ask the others if they want to jump in. Okay, so do either of you want to jump in? Either Ankit or Dipesh? Do either of you want to jump in and say anything? Okay, so if not, let me just jump to the answer. So Bharat, Dr. Bharat, what you said, no? Case control. So remember, in a case control, you need to have a case as well as a control. Okay, so here, what is the surgeon looking at? He's looking at the 15 patients that he has operated of medial sphenoid bending or clinoidal meningiomas with vessel encasement. So he's looking at the cases which he has operated. So from what we can make out in the scenario, there is no control arm, isn't it? He's just looking at the patients that he has operated, and he wants to specifically analyze these outcomes, isn't it? So that is a very specific type of study design, and it's just a case series. Okay, it's his series of cases that he's analyzing. And he's analyzing his cases. So that's a case series. And always remember, the ideal kind of statistics that a case series would yield is always descriptive statistics. Descriptive statistics means simple percentages. Okay, percentage of males was so much, percentage of females was so much, vision improved in, let's say, 70%, did not improve in 30%, or rate of vascular injury was 10%. So these are all descriptive statistics. And that is what a case series yields. Okay, so always remember, case series ideally yield descriptive statistics. You should not try to torture your case series into yielding any more interesting kinds of statistics, because it is not the ideal study design. Okay. So like I said, case series are also similar to cross-sectional studies, the previous design which we studied. So there is no longitudinal component. Longitudinal component means patients are not followed up from the time you decide to do the study. Okay. They're purely descriptive. Okay. And when do you say case series? Very arbitrary criterion is there by most journals. If you usually have more than 5 cases, you will say it's a case series. If it's less than or equal to 5 cases, you'll say that it's a case report. Okay. So it's as simple as that. It's a very arbitrary criterion. You can argue why not 7, why not 10, but this is what most journals follow. Okay. And you can analyze multiple factors. Like, for example, here the surgeon wanted to look at the rate of vessel injury, the visual outcome, the clinical outcome, etc. But the hallmark is that there is no control group. It is just a single series of cases with a disease or with some particular problem that you're analyzing. Okay. So you can look for very preliminary clues. Suppose you say that in a medial sphenoid wing meningioma series in 15 cases, suppose you say that 75% of the cases had vascular injury. That's not going to happen. I'm just giving you an example. Then you'll say, oh, this seems very high. So then you will think, should I go back and compare with the other types of meningiomas and let me see if there's a difference. So you look for preliminary clues about certain etiologies or risk factors. And so you use it for new or rare diseases. Okay. Like medial sphenoid wing meningiomas, if you take the subset of all meningiomas, they're not very common. So for slightly rare diseases, you will use a case series. Okay. So this is the hallmark of a case series. Okay. Now let me jump into scenario 3. So Dr. Dipesh, are you ready?
Yes, sir.
Yeah. So this is the third scenario. So one neurosurgeon is analyzing his series of patients whom he has operated for Moya disease. Okay. So he finds that out of 50 patients who underwent direct ST-MCA bypass, 7 of them have had perioperative strokes. That's 14%. Okay. Whereas 5 out of 30 patients who underwent ADAMS, which is an indirect bypass, had perioperative stroke. So 14% in direct ST-MCA and 16.7% in those who had EDAMS. So he wishes to find out if this difference in the rate of perioperative strokes, that is 14 versus 16.7%, he wishes to find out if this difference is significant. Okay. So the question is, how would you represent this data? When you want to make sense of this, I'm giving it to you in the form of a sentence. So when you want to make sense of it, how would you represent this data? And the second question is, what tests would be appropriate to analyze this data to find out the answer which he wants? Go ahead.
To represent this data, we have to a comparative study.
No, my question is not, I'm not asking you what is the study design. Okay. Comparative study is correct. You're right. But if you want to make sense of this data, 14%, 7 out of 50, and 5 out of 30, 16.7%. So do you know any standard way of representing this data? Okay. Do you want to answer the second question?
On,
what? Go ahead.
Based on the p-value and
yeah, p-value. I was waiting to hear it for the first time because in any talk or lecture about statistics, the p-value has to come up. So we'll talk about that. What test would be appropriate? Can you tell me about that? What test would you perform for this specific scenario? It's very clear, right? 50 patients, direct ST-MC anastomosis, 7 of them had perioperative strokes. 30 patients underwent EDAMS, 5 of them had strokes. So 7 out of 50 versus 5 out of 30. Is the difference significant? Basically, you're trying to find out whether ST-MCA versus EDAMS, which of them has a higher rate of strokes, whether this difference is significant. Okay.
T-test,
so,
T-test.
T-test. Okay. Anybody else wants to jump in? Or shall I give the answer? Okay. So let me jump to the answer.
T-test.
Sorry? Paired T-test.
Paired T-test.
So that's not entirely correct either. That's not entirely correct either. And I'll explain why if we have time. So let me jump to the answer. Okay. Remember the scenario, because the scenario only comes on this slide. The scenario won't come on the next slide. Okay. So the answer is this data, the standard way of representing it is a 2x2 contingency table. Okay. I asked you very clearly, how do you represent this data to make sense? So first thing you have to do is always arrange your data in statistics. So the best way of representing it is as a 2x2 contingency table, and it will suddenly make sense then. And once you have a 2x2 contingency table, the standard test which you're going to apply is a chi-square test. Okay. So let me show it to you. So you first set up the contingency table. So remember 50 patients were operated for ST-MCA, okay, of which 7 developed stroke, which means 43 patients did not develop stroke. So that value you have to get. Same way, 30 were operated with EDAMS, of which 5 developed a perioperative stroke. That means 25 did not develop a perioperative stroke. Got it? So this is your 2x2 contingency table. Very simple. You have ST-MCA here, EDAMS here, stroke and no stroke. Got it? So once you have this 2x2 table, then you calculate the chi-squared. And the chi-squared, I've given the formula, but that's just to tell you that you need not know the formula. Okay? You need not know the formula. There are easy ways. Which software do you all use? I want to ask the 3 participants, which statistical software do you all use when you write your papers, if you've written papers? Do you have access to any of them? So when we were residents, the most common one was SPSS. Okay, we used to use pirated versions of SPSS because Excel doesn't easily allow you to do all this. But nowadays SPSS is very tight. You can't pirate it. Okay. So an easier way of doing it is you can see my screen, right? So I'm going to open my browser and I'm going to go to something called OpenEpi. Okay. OpenEpi.com, and you'll be able to see my screen as I do it because I'm trying to be practical here. Okay, so this is the OpenEpi screen that comes up. And if you look carefully at the left column, you have an option.
Yours is in PPT.
Okay. My PPT is seen. Okay, I think I'll have to change the screen sharing.
You have to unshare and then go to that. Yeah.
Unshare and go to that. Okay, so let me just do that. I will
can
stop my share.
You can share your whole desktop. That way you can switch between screens.
Yeah, I think I'll do that. So I will. Okay, I'll share my desktop. Okay, is this better?
Yes, sir.
Yeah. So if you can see the OpenEpi on the left side column, you'll see an option called 2x2 table. Okay. So I click on that and then it takes you here. It's showing you a 2x2 table where it says you enter new data. So remember, I'm not entering all this. So you can actually enter here. So you can enter the variable name. For example, you can say ST-MCA here. So you can do that. I'm not doing that. So remember that 7 of them had strokes and 43 did not have stroke, correct? Whereas for
Okay.
EDAM,
Yes, sir.
5 had strokes and 25 did not have strokes. So this is what we have calculated here, right? This is exactly the same as what I had here. Now, can you see my PowerPoint? You're seeing this? It's the
Yes, sir.
same thing. Now, all you have to do is hit calculate here and see what it does. It calculates your chi-squared and it gives you your p-value, which you all are waiting for. And usually you would go with the mid-p. The mid-p, don't forget about why all the different types are there. Go with what the software highlights and see what the p-value is. It is 0.374. Okay, which means it is, it is not significant. That much we all know. Okay, so that is an easy way of doing it. If you don't have access to any software, basic tests you can do on OpenEpi, which is provided by National Institutes of Health, NIH USA. Okay, so remember this. So as I said, you can use OpenEpi or any other statistical software and you can calculate it. So I'll just briefly talk to you about this chi-square test. It compares 2 or more categorical variables. Okay, so if you're not having continuous numbers, like suppose you're saying age of a patient or weight of a patient or volume of a tumor, these are all called continuous variables because they can take any value, right? Literally any value. So if you're not comparing continuous numbers or if you're comparing percentages or proportions or categorical variables, remember to use a chi-square test. Here we had percentages, right? So that's why we used a chi-square test. So 2 or more groups with binary or percentage outcomes. And remember one thing, when you have very small numbers, like if it's less than 100 typically, chi-square test is very useful. Okay. All right. Now we'll move on to the next scenario, and I think we'll end up going back to Dr. Ankit. So,
Venkatesh, can I interject and make a comment there?
Yes, please, Chief, go ahead. Yeah, please.
Just as a word of caution to everyone that, when you calculate in a chi-square or in a contingency table, what you get as a p-value is there is a association, significant association, but it does not give you the strength of the association for which you need to calculate odds or risk ratios. I don't know whether you're covering that again in some other.
I will. So here, what Dr. Ali said is very, very relevant. In this case, we just had 2 percentages, 14 versus 16.7. We wanted to see if the difference is significant. Okay, so that's why we ran a chi-square test and I directly jumped to p-value. But as Dr. Ali said, it doesn't give you the magnitude of the difference or the strength of the association if you're looking at association tests. Okay, so I will come to that in one of the subsequent scenarios if we have time. Okay, so now let's go here. This is the 4th scenario. So a researcher has computed the preoperative tumor volumes based on MRI. I think this is to Ankit, right?
Yes, sir.
For 107 patients whom he has operated for acoustic schwannoma. Okay, so he wants to assess if there's any difference in the tumor volumes between those patients in whom the 7th nerve could be anatomically preserved versus those patients in whom 7th nerve could not be preserved. Okay, so these 107 patients he has divided into 2 groups, those in whom 7th nerve could be preserved anatomically and those in whom 7th nerve couldn't be preserved. So he wants to see if there's any difference in the pre-op tumor volumes between these 2 groups. So for this scenario, the first question is, what is the ideal statistical test for this scenario? So 2 groups, facial nerve preserved, facial nerve not preserved. So he wants to compare the tumor volumes between these 2 groups and see whether they are different. So what is the test which you would use?
Sir, the T test.
T test, very good. So this is absolutely correct. But before we say that, I wanted to ask you one thing. Remember that he has 107 patients. So before you jump to T test, do you need any further information to make a finer answer, to give me a finer answer? T test is correct. It is definitely one of the ideal tests. But anything else, if you want to be statistically very correct, because statisticians will never give you a simple answer. So if you want to be more specific, any other information, any idea? Either you or Bharat or any of them or Dr. Dipesh?
No,
okay, so let me answer the second question first. Okay, do you require any further information? Ideally, you need some more information, and that is you need to know if the tumor volumes between the 2 groups, 7th nerve preserved versus not preserved, you need to know if the tumor volumes are normally distributed. Okay, normally distributed means you all know what it means. It's a bell-shaped curve, which will be equal and symmetric around the mean value. Okay, like if you take those patients with preserved facial nerve and plot the values, it should be equal, symmetric on either sides of the mean for that group. If it's not symmetric, that means it is non-normal. Let's not go into types of non-normal distribution now, but that is important. How do you determine whether the distribution is normal or not? So for this, you have to use a statistical software, either SPSS or Stata or whatever it is. So there are many tests of normality. The most popular ones are Wilk-Shapiro or the Kolmogorov-Smirnov. Okay, this statistical software do it for you. But always remember one thing. Why I'm telling you this is, before you jump in and use the t-test, always remember when you're comparing two groups like this, the mean values or whatever, remember to find out if the data is normally distributed. Why is that important? Because that will determine what test you're going to use. Okay, and this is a very important table. So when you have two groups like we have, facial nerve preserved versus non-preserved, if the data is normal, okay, then you will use a t-test. But if the data is not normally distributed, that means suppose in one group all the volumes are less than 30, okay, and in another group they are all closer to above 50. It is not normal. It is not nice and bell-shaped. So if it is not normal, then you have to use something called a non-parametric test, and that the equivalent of the t-test would be something called a Mann-Whitney test. All these are available in the statistical softwares. Okay. Whereas on the other hand, if you have more than two groups, you all know to compare the means, if it is normally distributed, you will use an ANOVA. So 2 groups is t-test, more than 2 groups is ANOVA, 3 and more. Same way, if it is non-normal, 2 groups is Mann-Whitney, more than 2 groups is something called a Kruskal-Wallis test. Okay, so these are based on the medians, whereas t-test and ANOVA is based on means. So this is a very important table, and please remember this, because if you don't do the correct test, journal editors or reviewers will reject your paper, or they'll ask you to revise it, and it will look a little silly. So we have to be aware of the normality of the distribution and then decide based on that. Okay, so basically what we're doing is comparing groups. So whether you do a t-test or a non-parametric test like a Mann-Whitney, you remember that these tests will also yield p-values. This p-value is different. This p-value tells you the significance of the difference in the means. Okay, so basically, if you want to put it statistically, the p-value is the probability that the null hypothesis is correct. You all would have heard this term, null hypothesis. So let me explain very specifically with respect to our scenario. What was our scenario? Our scenario was with respect to acoustic schwannoma. Remember, facial nerve preserved versus non-preserved. What is the tumor volume, right? So here, the null hypothesis will state that there is no difference in the pre-op tumor volumes between the patients in whom facial nerve was preserved versus not preserved. There is no difference in the mean or median pre-op tumor volumes. That is what the null hypothesis will say. Okay. Whereas the opposite of the null hypothesis will say that there is a significant difference, naturally. Understood? Got it, right? Null means nothing. Null basically means nothing. So the nothing hypothesis says that there's no difference. That means if you take the mean of facial nerve preserved versus not preserved, there won't be a difference. The means will be very close, or the medians will be very close. Okay, that is the probability of this null hypothesis is what the p-value estimates. Always remember that. And arbitrarily, we say 0.05. So if the p-value is more than 0.05, that means the difference is not significant. The difference is not significant means what? Null hypothesis is correct. Got it? Okay, that means that there is a more than 5% chance that the difference is not significant. Whatever difference you're noticing, let's say it's 30% and 35%, it is just by chance this difference is not really significant. That is what it means. So I suggest you screenshot this slide and meditate over it a little bit. Okay, sometimes statistics needs meditation. So you can sit in Padmasana or whatever you want and stare at it and understand. Okay, because sometimes you need to do that. The answer is all here, but it's not straightforward because statistics sometimes is not straightforward. Okay, so remember that the probability that there is no difference between the groups you're comparing, which is the null hypothesis, is what the p-value gives. Okay, now we'll jump to the next scenario, and that I think is for Dr. Bharat, right?
Yes, sir.
Okay, so what this neurosurgeon is doing is he searches the medical records in his hospital and he finds 83 patients, okay, over let's say 5 years, who have developed ventriculitis post EBD insertion. Okay. So now he wants to determine what are the risk factors for ventriculitis in patients who have gone EBD insertion. Simple, right? That's what he wants to do. So what would be the study design for this situation? And back to our study design question, what statistic that this type of study generate? He wants to find out what are the risk factors for developing ventriculitis, because 83 patients over 5 years have developed ventriculitis. So what would the study design be? And what statistic would this kind of study design generate?
Case control studies. It's case control.
Case control study. Very good. And what kind of a statistic would you generate here? Any idea?
Odds ratio, sir.
Odds ratio. All right. Very good. Okay, so this is an ideal situation for a case control study, and it generates odds ratios, as he said. And this is a real study. Okay, I've taken the scenario from a real study. So where they've tried to identify risk factors for ventriculostomy, EBD associated infections. Okay, so I will quickly, before I explain, jump to the next scenario. And this, I think, goes to, we are going in alphabetical order. So who does it go to? Dr. Dipesh, right? So Dr. Dipesh,
Yes,
so here a group of researchers want to study the risk, what is the association or the risk of developing brain tumors with mobile phone usage. Okay, people who are using, we will not call them patients, people who are using brain tumors, what is the risk that they will develop people who are using mobile phones, what is the risk that they will develop brain tumors? So for this kind of a question, what is the ideal study design?
is we have to look cause to effect. It must be a cohort study.
Okay.
And statistics.
Okay, and what statistic will this generate?
Relative risk or attributable risk.
Very good, very good, very good. Relative risk or attributable risk. Very good. So here you realize that you cannot look at one set of people on one day who are walking into Vodafone office and ask them, do you have a brain tumor or have you been operated for a brain tumor? It's not going to work that way. You have to follow these patients over time, right? So when time is involved, always it becomes a cohort study. Okay, whether you're talking about patients, you're recruiting them now and following up them later over 2 years or 5 years or 10 years, or whether you look at mobile phone users from 10 years ago and look at how many of them have developed brain tumors. So that's a retrospective cohort study. So whichever it is, it's a cohort study. And as you said, cohort studies generate a relative risk. And this is correct. So this is a real scenario, right? This study has already been done. Okay. And why I club these two together is because there's usually some confusion between case control and cohort study. Okay. And I want to tell you the most important differences. Remember, in a case control study, you're comparing a group who already has a disease. In our scenario, it was patients with ventriculitis after EBD insertion. You will compare those with patients who had an EBD insertion but didn't develop ventriculitis. So here the disease is ventriculitis, not EBD insertion. In the whole group of EBD insertion, how many of them developed ventriculitis versus how many of them did not develop ventriculitis? That is the disease we are comparing. So, and then you look for exposures and risk factors. Okay, that's how we identified the risk factors. So what will be the risk factors? How often are you sending CSF samples? Okay, how old were the patients? Was there a difference? Okay, what was the indication for inserting an EBD? All those things. Was tunneling done versus not done? Those are all the risk factors. That is typical of a case control study. Whereas a cohort study, you're comparing the risks. For example, exposure to mobile phones versus those who don't use mobile phones. So that is a risk factor here. So you'll compare a group that has a risk factor with a group that does not have a risk factor. And you are going to see, did the likelihood or the risk of developing the disease, which is brain tumor, did it change? Okay. So this can be prospective or retrospective, as I said. Okay. So these are opposite. In case control study, you're dividing the groups based on disease. Whereas in cohort study, you're dividing the groups based on the risk. Got it? The next slide. I'm again emphasizing the same thing. Here it is identified by disease. Here it is identified by risk factor. And therefore here the outcome is odds ratio. What are the odds of developing a disease in the exposed with the risk factor versus those without the risk factor? Whereas here you're talking about how much does the exposure increase the risk. Okay. So this is summarized by this very nice flow chart. Okay. As I said, in case control, you have patients with disease who are the cases, patients without the disease who are the controls, and then you have risk factor, no risk factor, risk factor, no risk factor, and you get an odds ratio. Whereas in cohort study, you have the risk versus no risk. Here it is, for example, smokers versus no smokers. And the disease is lung cancer versus no lung cancer versus no lung cancer in these groups, and you're going to get a relative risk. Okay, someone's raising a hand. I'll ask them at the end of the talk because I think, Dr. Suchanda, you need to tell me when to stop. Okay. Okay, so this is again, hello?
Yeah, you carry on. There are still some more.
Okay, fine. Thank you. Okay, so I think I'll come to the questions in the end because I'll try to cover as many scenarios as possible. Okay. So we'll move on to the next scenario. So remember, misclassification of case control and cohort studies is very big of an issue, very big issue. So you have to be very thorough with this basic. Okay. So I don't know, some user called Dr. Lukman Hadi is raising his hand. As I said, we'll get to that in the end. Okay. We'll move on to scenario 7. I think it goes back to Dr. Ankit. So I'm telling you that the current 2-year survival rate for patients with glioblastoma is 18%. So if you look at patients with GBM at the end of 2 years, 18% of them will survive for 2 years. So one researcher thinks that adding a new drug X to the standard regimen of radiotherapy with temozolomide after surgical excision will improve the 2-year survival by 10%. That means it's going to jump up to 28%. Okay. So what statistical factor would determine the sample size for this kind of a study that compares radiation plus temozolomide with RT temozolomide plus drug X? What is the most important statistical factor that would determine the sample size? I'm not asking you for the sample size. I'm asking you what factor would determine the sample size.
Sir, a confidence interval will be the factor.
No, confidence interval won't determine, because when you say that you're giving a specific ratio, for example, if you're saying odds ratio or a relative risk or a hazards ratio, you'll have a confidence interval for that, a 95% confidence interval. But I'm asking you to determine the sample size. What is the most important parameter you have to consider? Either Dr. Bharat or Dipesh, any idea?
Survival percentage.
Sorry?
Survival
Prevalence.
No, it's not prevalence. It's not survival, because we're already taking patients with GBM, right? So in this case, what you need to look at is the power, okay? The statistical power. And power is nothing. It's basically how confident. So when you compare these two groups, RT temozolomide with RT temozolomide plus this new drug X, okay? And when you find a difference between these two groups, let's say that 18% 2-year survival here and 28% 2-year survival here, okay? When you're saying that the difference is 10%, how confident are you about this fact that this difference is significant or it's a real difference? Okay, that is what power tells you. Okay, so if you look at it, power is basically the chance of finding a difference where a difference exists. So there's a 10% difference here. Okay, so what sample size is going to be enough to actually detect this 10% difference? Suppose you take 4 patients. Okay, 2 of them you give radiation and temozolomide, 2 of them you give radiation, temozolomide, and this new drug. Okay, do you think this 2 and 2 in each arm is enough to determine the difference? It's a very small sample, and you may miss out on this 10% cut difference, isn't it? So what is the sample size that is required to find this difference, this 10% difference? Okay, and what is the chance that you will find it with this sample size? Okay, that is what the power tells you. So it's either the chance of finding a difference when there is a difference, or the chance of rejecting that the difference does not exist when there is really no difference. Both. It's 2 sides of the same coin. Or wherever there is a null hypothesis, there are always 2 sides to the same coin. Okay. So how do you increase the power? You can increase the power when you increase the sample size, or when the difference between the 2 groups is very big. Like suppose you add drug X. Okay. Without drug X, 2-year survival was 18%. Now, after adding drug X, suppose 50% of the patients are surviving for 2 years. That's a very big difference, isn't it? So that will also increase the power of your prediction. So in that case, you may not need hundreds of patients. With just 20 patients in each arm, you may be able to make out a difference, right? Or if you have a very widely scattered data, like we looked at the acoustic schwannomas, remember? Suppose the volumes of the tumors are like very widely variable. One tumor is 5 cc, other tumor is like 55 cc. When the data is scattered, your power will reduce. Okay, remember that. Okay, so you need to maximize the power. Usually, what is the power we keep? Any of you? Usually, what is the power we set in statistical studies for medicine? We usually set a power of 80%. Minimum acceptable power is 80%. Okay. So we don't have control over the data, how scattered it is, what is the mean, or what is the difference between the means. We don't have control over it. But what you do have control is over your sample size, right? So when you choose your subjects, number of subjects to get 80% power, that is a power calculation. And again, what I'll do is I'll go to this OpenEpi page. Remember, we have it open here. If you see, there's an option to select power here. Okay. So above power is sample size. So if you want to calculate a sample size, see what we are getting here. There are various options. So we are trying to see drug X versus no drug X, right? So that would probably be either a case control or it would be a RCT, randomized control trial. So if we pick that it's a randomized control trial, okay, this is the table that we get. So we want a 95% confidence interval. Remember, one of you said that. So our confidence interval, we want to keep it at 95%. We want to set 80% power. Okay. And the ratio of patients who are receiving drug X to no drug X, we'll keep it as 1:1. You can change this. You can make it 2:1. You can make it 3:1. It's up to you all. Okay. There are various situations. I don't want to go into those technicalities. Now, the patients who did not have drug X, what was the 5-year survival? I said it was 18%. Remember? Back to the scenario. Whereas if you give them the drug X, I said the patients who have 2-year survival becomes 28%. Okay. So the outcome here is 2-year survival. Without drug X, 18% had. With drug X, 28% have. Okay. That's all you need. Now you plug this in and say calculate. See what's happening. So the total sample size you need is 279 or 278 in each arm. So to detect a 10% difference between these groups with an 80% power, you need 279 patients or a total of 558 patients in your study. Anything less than this and your conclusion will not be statistically valid. And that is why it is important. Okay. When you're spending thousands and tens of thousands and lakhs of rupees and running a randomized trial, if you don't do this power calculation beforehand, your results will be rejected as not being statistically valid. Okay, that's the point I wanted to make. We'll go back to the previous scenario. Okay, this is open to all of y'all. Okay, so the current 2-year survival, as I said, is 18%. And I said that the researcher thinks adding drug X is going to increase it by 10%. So what is the sample size that I already showed you? Okay, how to calculate it. So we got the answer. It was 279 patients in each arm. Okay, we'll quickly jump to the penultimate scenario and I'll see if we have time for the next one. So going to this, a pediatric neurosurgeon wants to study if there's any difference in clinical and radiological outcomes with and without duroplasty in children who are undergoing foramen magnum decompression for Chiari 1. Whose turn was this? I'm sorry, I lost track. Dr. Bharat. Okay. So kids with Chiari type 1, you're doing FMD, foramen magnum decompression. So question is whether you want to do duroplasty or only do bony decompression, remove foramen magnum and C1 arch. Okay. So this researcher wants to see if there's any difference in the outcomes between these two groups, whether you do duroplasty or not. So the simple question, what study design would be appropriate for this research question?
Randomized control studies.
Very good. So the answer is indeed randomized control trial. Okay. And you need to do a randomized control trial because there can be so many other variable factors in these kids. And you want to make sure that these random variable factors or covariates as they are called are equally distributed between the duroplasty and no duroplasty group. Okay. That's why it becomes an RCT. And this RCT has been done. Remember? So this is a RCT which was published in 2017, duroplasty versus no duroplasty. And if you're curious, the conclusion was that duroplasty does not improve clinical or radiological outcomes. They found that in this study, bonectomy, I mean, as we can say, alone was enough. Okay. And remember that if you look at the evidence pyramid, RCTs come under class 1 evidence. Okay. Animal studies aren't included. Case reports, case series are level 5. Case control can be level 4 or level 3, depending on how well you're controlling for the variables. Cohort studies are level 2 and RCTs are level 1. Again, in level 1, depending on if it's a single RCT or a meta-analysis of RCTs, it can be level 1A or below level 1A. Okay, fine. So RCTs don't control with case control studies because here also patients are identified with the disease. But here the exposure or what intervention you're doing, for example, here duroplasty, no duroplasty, that is assigned randomly. Okay. Now I have a second part of the question. Dr. Bharat, can you tell me a few types of randomization, if you know any? A couple of types of randomization. Any idea? Any of the others? Yeah. Anyone can chip in because we're reaching the end of the seminar. Any of y'all can chip in. Very good. Stratified randomization. Any other type? You went to the more complex one first. The simpler one is simple. Yeah. The simple one is simple randomization. Correct. And block randomization. So these are many types. Okay. Simple randomization is very clear. As and when you get the patients, you pick out a random number and decide which group you're assigning them to. What is the problem here? The problem is that you may not get equal number. Suppose you want to do an interim analysis. Okay. Suppose you feel that duroplasty is going to be dramatically better. And you feel that after say 50 patients, you want to do an interim analysis. The problem is if you do simple randomization, you may not have equal number of patients in each group. It may be very widely different. You may have 15 patients in one group and 45 patients in one group. So your interim analysis may not be valid. So to overcome that, you can do a block randomization. That means you say every 10 patients who come, I'll randomly divide them between two groups. Then the next 10 patients, again, I'll randomly divide them. But what is the problem here? The problem here is the covariates may not be equally distributed. Okay, so in covariate can be anything. Okay, whether the kid was born to consanguineous parentage, non-consanguineous parentage, okay, whether the kid has any other dysmorphic features, doesn't have dysmorphic features, hydrocephalus, no hydrocephalus, none of these variates may be distributed. So you can control for those also, and then you can do a stratified random sampling. But here we are becoming more and more complicated, and I don't want to talk about dynamic because then I'll never finish. So these are some types. And you have to generate random numbers in order to randomize the patients. And there are many ways to do that. You can just open a book. You can buy books of random number tables, or the computer can generate it for you. There is software, or you can just simply calculate the distance between primes. And remember, in number theory, the distance between the subsequent prime numbers is always random. It's not fixed. So this is one way in which you can do it. Okay. My last question on this scenario, I think it's the last question. Can anyone tell me the difference between double and triple blinding? Because whenever we talk about RCTs, it will always be randomized, controlled, blinded study. So what is the difference between double and triple blinding?
Both participant and investigator are blinded, sir. Double.
In which one?
Double.
Okay, and what is triple then? Very good. What is triple?
Statistician also blinded, sir, in triple.
Very good. Data assessor is also blinded. So it's very simple. So there are three people involved here: a participant, the study subject, investigator, and the data assessor. Principal investigator is not included in this table because principal investigator can always break randomization in emergencies. Okay. So based on who is blinded, that is who knows which patient is in which group, you can have an open label study where nobody is blinded. Everybody knows what they're getting. Single blinded where only the subject is blinded. Double blinded if the subject as well as the investigators in the clinic are blinded. Or triple blinded where even the statistician is blinded. Okay. So these are the types of blinding that we have. So I think it's time, right, Dr. Suchanda? We should stop, I think, isn't it?
Yeah. One more, maybe we can go because
I have only one more. So I have the last scenario. So then we'll quickly finish the last scenario. Okay, fine. So we'll keep this as open. Although it's the 9th one and so I'll go to Dipesh. If Dipesh wants, he can take it. Okay. So a researcher finds that patients diagnosed with GBM who have a preoperative inflammatory state in the peripheral blood, that is high neutrophil count, high NLR, neutrophil lymphocyte ratio, etc., may have a worse survival than patients who don't have an inflammatory state. Okay. So he stratifies the sample of patients that he has operated for GBM around the presence or absence of an inflammatory phenotype. So patients with inflammatory phenotype, those without inflammatory phenotype. Okay. Inflammatory phenotype can be anything, high neutrophil count, high NLR, like I said. So those with and those without. And he wants to see if there's a difference in the survival between these two groups. My simple question is, which test would be appropriate or which analysis would be appropriate for this scenario? He wants to look for differences in survival between patients who had a preoperative inflammatory state versus those who did not have an inflammatory state. I'm sure Dr. Ali is smiling. Yeah, exactly. So any idea? Any of you can take this quickly. If not, then I'll jump to the answer. Should I jump to the answer? Okay. So remember what we're doing is we're dividing the group of GBM patients into two: inflammatory state, no inflammatory state. And we are looking at survival. We want to see if there's a difference in survival. You should know this because when you read journal articles, you will invariably come across this type of analysis. And that's called the Kaplan-Meier survival analysis. Okay. And if you don't recognize the name, you'll certainly recognize the graph, and the graph looks like this. Okay. This is a Kaplan-Meier survival analysis. And if you see, patients who have inflammatory profile are depicted along the blue line, and those who don't have the inflammatory profile are depicted along the red line. And you can see that the red line is above the blue line, and some test is showing a difference of p equals 0.001. What is this basically? Basically, what this tells us is that at every point that you follow up the patient, suppose you're following up the patients monthly, okay? GBM patients who have been treated, who have completed radiotherapy, if you follow them up monthly, at every follow-up interval, what is the proportion of patients in that group who are alive? Because here we are talking about survival. So patients who had an inflammatory profile, how many of them are alive at the end of 1 month? Those who did not have an inflammatory profile, how many of them are alive? At 2 months, how many of this group are alive? What proportion of this group are alive? That is what this graph depicts. Okay. And what you can see is at every point in time, this red line, that is the patients who did not have an inflammatory profile, like say a high neutrophil count, you can see that a higher proportion of patients are alive, right? That means those who didn't have inflammation are likely to survive longer because they have a higher survival. Okay. And that is what a Kaplan-Meier graph depicts. Did you understand? It can be anything. IDH mutant versus IDH non-mutant. You all know that IDH mutation is important for GBM. So IDH mutant can have a higher survival at every point in time than IDH wild type, non-mutant. So it can be any two parameters, okay? And the survival graph is the Kaplan-Meier graph. And this is very important. And I'll tell you one more interesting thing before I close, okay? From this graph, you can get one more parameter, and that is what is the median survival for each of these groups. So the patients who had an inflammatory profile, those who didn't have an inflammatory profile, what is the median survival? The way to get the median survival is, look at this. 50% of the patients are surviving here, 0.5, okay? So come to this curve and find the corresponding period of time along the x-axis, okay? Do the same thing for this, find the corresponding time along the x-axis, and that gives you the median survival, okay? So that is what a Kaplan-Meier graph tells you, and you will invariably see this. Last question is, suppose the patient has not died or does not have disease progression, and you finish your study. You've stopped your analysis. Your study is over. Okay. What happens to his data in this graph? Any of you know quickly what the term is? So the term is very important again. It's called right censored. Right means this is the right side, literally the right side of the graph, right? The study is over, but the patient has not had the outcome. The outcome can be death or recurrence of disease. So at the end of the study period, if the patient has not had that outcome, then you say the data has been right censored. See, in a GBM, I'm not being very pessimistic here. You all know that normally almost all patients will either die or have a recurrence, right? So in that case, the probability of survival should touch zero here. The proportion of patients surviving should touch zero. Why is it not touching zero? Because either some patients will drop out or your study is too short to pick up the recurrence. Those are right censored, and that is why these curves are not touching zero. Okay, these are very important concepts that you should know about Kaplan-Meier analysis. I will stop here because this can go on and on, but I hope I've introduced you to the basic statistical tests and concepts. And I apologize if I haven't been clear or if I've been very fast. And I think people were raising their hands. I just didn't have time. I'm sorry. Yeah, so that's all from my side. I don't know if you should take questions or we can do it by email or something, whatever you suggest.
Questions, there are a few questions, you can answer them.
Okay, so let me go to the chat box, or is it under Q&A? I'm not sure where to find it. I think in the chat box. Can we analyze retrospectively patients with brain tumors and exposure to mobile? Yeah. So going back to that scenario, the answer is yes, because that's what I said is a retrospective cohort study. So you go back 15 years in time, divide your people among those who use mobiles, don't use mobiles, and look at how many of them today have had brain tumors or have not had. That's a retrospective cohort study. Okay. So yeah. Any more questions? Yes, double-blinded participation and researchers blinded. What more questions are there? I think mostly there are answers. Okay, so if anyone is live raising their hands, maybe one question or two questions we can take. Somebody is raising their hand, so should we permit them to ask whatever you say?
Yeah, we can permit.
Okay, so I think one or two questions. So please go ahead and ask very quickly so that we don't overrun time dramatically. Please go ahead. Who?
Any of the audience, means any of the students can, or
yeah, those who are raising their hands.
Is there any, Sriram, is there anybody who is raising the hand? Because I'm not seeing anybody.
I allowed them to talk.
Some Lukman and some Rajendra.
Yeah, I couldn't see that now. So yeah, please go ahead. One of you at a time, quickly.
You have allowed them, Sriram?
Yes, sir. Yes.
Okay. Again, I'm seeing two participants raised hand.
They are in also.
They had raised earlier, probably.
Yeah, I think they've raised earlier. Okay. So then if no questions are there, we'll wind up, sir. Thank you very much.
Yeah, means it was very interesting. Both Dr. Ali and Dr. Venkatesh. Venkatesh all the time makes complicated things very simple. And
thank you, sir.
Yeah, so that is why means I have to thank both of you for accepting to be a faculty at a very short time and to make to work on it. Like I know that it involves a lot of work to things, make it simple and make people understand. I also clarified many of my doubts of my statistics, which we had forgotten long ago. And thank you, Venkatesh, and thank you, Dr. Ali, for teaching pathology. I'd like to thank Dr. Chirag, who shared the specimens.
Thank you,
and
sir.
I cooperated to Ali.
Yes.
So, and thank you, Dr. Suchanda, for coordinating, and I hope you enjoyed the slide presentations of both Dr. Ali and Dr. Venkatesh. And Dr. Sriram for thanking him, because all the time he does all the logistics in proper way, and all the audience and all the students who came forward to be examined without any hesitations. Dr. Ankit and Dr. Bharat and Dr. Bharat, who came in the last minute.
Yeah. And Dr. Dipesh.
Yeah. And Dr. Dipesh. So next time again we'll meet. This was an extra class. Usually we do on first Saturday every month. So we meet on first Saturday of September. Is Dr. Suresh Nair there? Professor Suresh Nair?
I'm not seeing.
Next class, we want a brief idea on how ward rounds will be, sir, because we have discussion. Ward rounds will be, sir.
Ward rounds.
Yes, sir. 40 marks we have on ward rounds, sir.
Yes.
So ward rounds means what? They give clinical scenario and ask, or how do they do? Chirag, you have the experience of the exam.
Ward round, I did not have experience, but I have heard from the seniors, sir. We will get back, sir. We will find out what they are used to do.
This time the total 4 cases will be there, sir.
It's just like the round only.
Yes, sir.
One table on recent advances.
Okay.
It's like case scenarios in going through the ward and then asking all complications and all those.
Yes.
Managing a patient.
4 cases, each case will be having 10 marks. 4 cases will be there, sir, in ward.
Yeah, so I'll request next time faculty to do it in form of ward rounds, take case scenarios and do that.
Yes, sir.
Okay.
It's just like, you are concentrating on trauma case or something, you pick up a scan and like we do in the ward rounds, exactly that.
Okay.
Sir, few slides of Aliasgar were left. We couldn't cover those slides. So can we get those slides?
Ali, can you at least present the slides in very fast so that it will be recorded and then they can see that?
Yeah, sure. Why not? So
yeah, please share your screen.
Thank you, sir. Thank you, sir.
I think Venkatesh needs to stop sharing first.
Yeah, sorry. I didn't realize I was still sharing. Yeah.
Okay. All right. So you all can see the slides now? Yeah.
Yeah, yes.
All right. So I'll quickly go through that. So the 5th case was actually this specimen, which is obviously a pituitary adenoma. And I would have expected to briefly describe, and it was being targeted around incidentalomas. What would be the evaluation of incidentalomas, which are actually quite common, and the radiological classification or grading of pituitary adenomas in terms of their aggressiveness. And we all know of modified Hardy-Wilson and the NOSP classification, which indicates the radiological aggressiveness of these tumors. And for incidentalomas, the treatment, of course, is wait and watch unless there are certain red flags, which include visual field secretion or documented serial growth. And what I wanted to highlight here was, again, the pathological classification of pituitary tumors, which has changed recently. And we no longer call them pituitary adenomas, but pituitary neuroendocrine tumors or PITNETs. And that's based on subtyping, based on their adenophyseal or neurophypophyseal lineage. And there are transcription factors, basically PIT1, TPIT, and SF1, which determine the diagnosis of these tumors. And this is just a snapshot of what the classification of pituitary tumors is. And important to understand also that pathological aggressiveness of the tumor is not equal to radiological invasion. Bone invasion radiologically is not always equal to pathological aggressiveness. There are strict or defined criteria which actually reflect the propensity for recurrence in these tumors. And that is what I wanted to highlight. And the last case was actually slides. This is basically a round cell tumor. And medulloblastoma, which is the commonest malignant posterior fossa tumor in children. And this slide was depicting the 4 typical pathological subtypes: classical, the desmoplastic, the large cell anaplastic, and the extensive nodularity M-bend types of medulloblastomas, which actually are a spectrum of primitive neuroendocrine tumors. And nowadays, we do not actually refer to, and WHO 2021 does not require you to specify the histological subtype. That is what has changed, and all of you should be aware of the molecular subtypes of medulloblastomas, which is based on very well characterized pathways into Wnt, SHH, and the 2021 classification groups 3 and 4 together as non-Wnt, non-SHH pathways. These are well-defined clinico-demographic features, radiological features, as well as diagnostic features. So this is important to understand, and the treatment also depends on that. And the last aspect would be, of course, treatment of medulloblastomas. For neurosurgeons, you need to know what is the surgical approach, telovalar versus transvermian, pros and cons, and the principles. And the adjuvant therapy is based on risk stratification. Earlier, we used to follow this average risk, high risk, which is yet followed in many places. But keeping pace with the molecular classification, now the risk stratification has changed a bit, incorporating these molecular factors within that risk stratification. I think this is important to understand. That's it.
Thank you, Dr. Ali. And then I think Dr. Bharat, you're satisfied now with all the...
Yes, sir.
Okay.
Yes,
So,
thank you, sir.
So next time, Dr. Chirag, you have to find the volunteers for the next session. And I'd like to thank all of you again. And then again, I want to thank Dr. Sriram for coming up on a Sunday and doing all the logistics for the extra session. And thank you, and good night. Before I tell good night, I'd like to request Dr. Ali, Dr. Venkatesh, and Dr. Suchanda to tell a few words for the students.
I mean, let me start. I mean, I really need to thank Dr. Venkatesh, because all those things, we are forgetting. And if you are not reading, like I thought that if I sit for this kiosks for exam, I'll not pass for sure. Same with neuropathology, you just need to go on brushing up. We are so busy operating, and then we don't focus on all these things. So this actually stimulates you. Today, I thought that I'll go and read a little bit of research. I have to start reading. So that's my take home from this one. And I think the students are doing good if they are giving for exams. I mean, they could answer around 70% in both the sessions. So that's a very welcome change, So all the best to all of you. And thanks both of you for teaching so well. It's always a learning for us as well.
Yeah, no, thank you very much. I think Dr. Suchanda, Dr. Manas, thank you. I think the students did brilliantly. I think they did very well. I think Venkatesh had a very complicated statistics. He made it very simple, actually, and it's very important. I think statistics and clinical research methodology is something which everybody should know, because that's how you analyze your own work and get feedback. All I'd like to tell all the students is that you all have done well. You all are doing well. Keep it up. You have exams coming soon, and all the best.
Thank you, sir.
I also want to thank Dr. Manas and Dr. Suchanda and Dr. Chirag. These sessions I realized are always a lot of fun. And and I also got to read statistics and make these scenarios. I also read the papers which I showed. That was also fascinating for me. I don't know how Dr. Manas identified this topic, but this is something which I always like talking about. Although people say it's dry, I really love talking about statistics and study design. So I think inadvertently, or maybe it's new, but I think this is one of my favorite topics. So I just hope I've done justice. Dr. Ali is a very good teacher. I have learned from him so much. So I think he did a brilliant job. And the students were also very good. So thanks to all of you for giving us this opportunity, both to teach and to learn. Yeah, thank you.
Thank you. Thank you. Good night.
Good night, sir. Good night,
Good
Dr.
night.
Suchanda.
Bye. Chirag, you're there or gone?